I think they've given me a little bit more time than I have. I think I'm a 7-minute talk, but anyway, thanks, Fred. These are my disclosures, and they are pertinent in the sense that I do receive royalties for intellectual property, both in CR, CS, RP, and revision. So the rest of them are really not pertinent. When I first started, 90% of knees were being done with cruciate retention. Then came cruciate substitution, and eventually, or before that, was cruciate sacrifice. And then there's been a steady decrease to where the numbers are about 60% CS and about 40% CR, even though in the American registry, they were about even or slightly above CR, but they don't have them all captured. And the reason for the decrease was the CR was felt to be too difficult. It would either be too tight or too loose. And they said that flexion balance was harder to do with a CR knee, which has not been my experience because I use both. The clinical data rarely showed any difference that was significant. And much of the cruciate retention failure was associated with flat-on-flat articulations at that time, with bad polyethylene that was gamma radiated in air, and with early instrument systems that tended to promote flexion instability and mid-flexion instability. This conference on emergent technology is talking about a lot of the things that you see here. And I think, given the fact that the clinical data is not that different, I think that this may tend to have people increase the amount of CR knees done. And we'll just go through that, remembering the clinical data wasn't any different. There's a bunch of navigation systems that are well in the market already. It may give somebody a bit of a better sense of coronal alignment, makes them think a little bit more. And there is a marketing issue to all of these things. I'm not going to reiterate that, but that is the elephant in the room. Custom guides, custom implants, lots of systems have them. I do not use them in the system that I use. Helps a bit with pre-op planning and maybe fit and fill and sagittal and rotational alignment. Medial pivot is something that has gotten some increased into. This is one of the early ones that was cruciate retaining. Many of them are cruciate substitution now, where the dwell point stays in the center on the medial side and rolls back laterally. The CR knee I use does that anyway, and not really specifically considered a medial pivot. Felt to be more kinematic, saying, well, what should run this? Should the prosthesis run it or should the soft tissues run it? My feeling is this should be soft tissue driven. If you drive it with a prosthesis, you're going to increase some of the constraint on the implant. And I think the posterior cruciate is a key soft tissue in the knee. Robotics, we've talked a lot about it. They're very popular now. The data are depending on what you really believe. Give surgeon the feedback, felt to be for them a better reproducibility, alignment may be better in their hands, and they are beginning to work on soft tissue balancing. I do not have experience, though we have it in our institution, but with the robot. Kinematic alignment has had some popularity, say that more reproduces normal alignment. The PCA had some of that, which also was destined with some other problems. It will allow some tibias varus and almost require it. And probably if you stay less than 3 degrees or 4 degrees, you're okay. Steve Howell in a recent View Medi thing came up with his quote commandments. And one of them was that thou should save the posterior. The rationale of cruciate retention and flexion is that it stabilizes the discrepancy between the medial collateral ligament and the lateral collateral ligament. You can see the posterior cruciate, which is really one of the strongest, and normally the lateral side is more loose in order to allow for rollback. This is the most important thing, and it shows that as you tighten the medial side, you can see that the lateral side follows, and you get a box between the medial collateral ligament, which is strong, and the posterior cruciate. The lateral side is more loose, and if you put this on, so people who really feel that they get a true balance of the posterior cruciate, I think it's not really fully attainable, nor should it be, because this allows for rollback laterally. Here's a cruciate that's too tight. You can see that in that situation, here it's now balanced, where you see the dwell point is in the middle and there's no liftoff. So the advantages of cruciate sparing, in my opinion, is it is bone sparing because you tend to take off more distal femur. It's another soft tissue constraint, allowing the soft tissues to drive the kinematics, and a few others, but they are not as important as the first. So it's my feeling that you can do a knee by cruciate retention, by cruciate substitution, by rotating platform. But what you really need to do is to know the principles. And if you do that, you're going to get good results on a consistent basis. It's a great operation. Thanks very much.